If you work with TPN, these are 4 questions you've either asked or have been asked. First up, does TPN require a central line? TPN should be administered via a central line because of its high osmolarity. Osmolarity is simply a measure of concentration. TPNs, although not always, tend to be highly concentrated in protein, dextrose, and lipids. High osmolarity solutions pull fluid from surrounding tissues, causing damage to small veins, which is known as phlebitis. The vein can be so damaged that the infusion leaks out of the vein and into surrounding tissues, causing extravasation. The immune response to tissue damage causes an influx of inflammatory mediators that will form clots over the damaged areas. This can cause thrombophlebitis. Administration into a central line allows for quick dilution of the hyposmolar TPN into a larger central vein, which reduces the risk of these adverse effects with peripheral administration. The next thing you need to know is that all TPN requires use of an inline filter. A filter is necessary to reduce the patient's exposure to microorganisms, air emboli, microprecipitates, and microparticles. The current recommendation is for all parenteral nutrition to be filtered with a 1.2 micron filter that is placed close to the patient, not the bag. Next up, compatibility. Line access is valuable real estate in healthcare. Ideally, TPN should have a dedicated line for administration for 2 main reasons. First is the risk of infection. TPN is a highly concentrated dextrose solution, making it a favorable environment for bacterial growth. Each time that line is accessed, to change from TPN to another medication is an opportunity for central line-associated bloodstream infections or CLABSIs. We want to minimize manipulation of the line and minimize access to the port as much as possible to reduce the risk of bacterial transfer. A dedicated line also reduces the risk of precipitation. TPN is a sensitive formula. It is light sensitive, pH sensitive, and temperature sensitive. Every exposure matters. Running other medications through the same line as TPN can change the pH and cause precipitation from the combination of medication. Another key question is how to stop TPN. When we eat, absorption through the digestive tract introduces glucose gradually. There is a rhythmic rise and decline in blood glucose with a corresponding response in insulin release from the pancreas. Typically, TPN is a constant infusion. There is no period of fasting, and insulin release mimics this steady output. If we suddenly stop a TPN, insulin release remains elevated for a short period of time. In some patients, this can cause hypoglycemia. Because of this, we titrate patients off TPN. This allows the pancreas time to decrease the levels of insulin circulating in the blood.